Good afternoon. It is my real pleasure and honor to be speaking at the NIAAA 50th anniversary celebrations. Thank you, Dr. Koob. I'm going to be speaking about alcohol's dark side and the role that stress plays, particularly stress neurobiology, in both the risk of developing alcohol use disorder and also the recovery from alcohol use disorders. So, of course, you look at these images here. These are all images of partying, fun, pleasure, reward. These are words that come up when people think about the word alcohol or have to identify what's most commonly associated with alcohol. Partying and fun comes up right away and very commonly. And in fact, those are the images about alcohol that come up. And yet there is also the other side, the side where anxiety, pain, distress, depression, and drinking under those conditions come up. And the question, the toggle between these two sides, these two paradoxical or dialectically opposite, perhaps, sides of alcohol are the pleasure, fun, reward, and the distress, anxiety, pain side of it. And the shift from one to the other, particularly going towards as Dr. Koob has so beautifully identified, going towards the dark side, is the building from desire, healthy, normal desire, to craving and then compulsion. So there has been a well-known bidirectional relationship between stress and pleasure or reward. We know that in the case of alcohol, but even other drugs of abuse, increased levels of stress or trauma actually may alter how much reward we feel and the response to stress that we may have. So there is this bidirectional relationship. In fact, there are data that show that high stress and anxiety may enhance the feeling of reward or the need for reward, and then high levels of reward may enhance stress. But how does that relationship actually break down and play out? We are in the middle of the coronavirus crisis currently here in the United States, and there has been quite a bit of attention on how COVID stress has increased alcohol use. Here's a USA Today article reporting on the fact that Americans are drinking more amid the COVID-19 pandemic. But experts and all of us have talked about how this could be, any relief from that could be temporary. In fact, on-site sales of alcohol are, of course, down as places have been closed down and restaurants have been closed down, but e-commerce is now allowed, and e-commerce profits have increased over 30% during the COVID-19 pandemic. And the beverage industry says that their sales overall has not increased. So what is going on here? And again, the question could be, who is most susceptible to these increased drinking episodes during COVID stress? And right here in this year, in the pandemic year, we see that in fact, this bidirectional relationship between stress, in this case, COVID-related stress, the isolation from COVID, the change in our lifestyle, the break of our regular lifestyle and habits, sort of driving certain individuals and certain groups of people towards increased levels of drinking and greater risk. So I'm going to focus on alcohol effects on reward and what may be the link to stress, and particularly to how we cope with stress and the positive or the resilient coping mechanisms that are hardwired in our brain. There are sex differences in stress responses that can be shown during development and really in adulthood, so across the lifespan. So I will talk a little bit about that. Then I'm going to also talk about how binge and heavy drinking and alcohol, high levels of alcohol consumption can alter our biological stress pathways, both in the brain as well as in the periphery, in our bodies. And that is tied to increasing risk for alcohol use disorder, as well as our vulnerability to relapse and in jeopardizing recovery from alcohol use disorder. And finally, I will end with asking the question and showing how we are targeting whether we can promote recovery by targeting this alcohol-related pathophysiology in the stress coping circuit. I like to call this the stress pathophysiology of alcohol use disorders, and whether if we target that, could we improve our treatment outcomes? So here is a cartoon of a face with the brain, a sagittal section of the brain. And what you can see here is the dopamine-rich regions, what is often identified dopamine as the pleasure chemical. I like to call it actually the motivational chemical. And it's involved in reward or in motivation. And here's the ventral tegmental area, the accumbens reward region, and then this frontal system, the prefrontal cortex, that helps us regulate our reward impulses, the need for pleasure, with sort of balancing it with self-control. Now, before we had all of these rewarding substances that stimulate this pathway in the brain, the question we raised in our laboratory is, what about stress-related motivation? What about when we are under stress, the need for reward or the need for saving ourselves or to survive, to improve our certain state in the moment? Before we had all of these rewarding substances, in fact, that we were hardwired to deal with stress and to save ourselves or adapt under conditions of stress so that we can come out on the other side, learning from the stressful experience and not having to go through it again. One of the studies that we did a few years ago was to look at the neural mechanisms of resilient coping under stress. How do we are all faced with stress every day of our lives. In fact, we are in the middle of a pandemic, and yet people are coping. A lot of folks are drinking and having difficulties, but there are others who are coping every day in an active way and doing the best they can. And we wanted to understand what we call the resilient coping mechanisms in the brain that drive this response to stress. What we exposed healthy individuals, a group of 30 individuals, to was a bunch of stressful images. These were really threatening, challenging, very gruesome, as well as fearful images. And that was one block. And then people were exposed to neutral, relaxing, sort of calming images. And that was a second block. And these blocks people were exposed to in a random way, in a counterbalanced way. And we also assessed the stress hormone cortisol, stress arousal during this period. And what we identified first was that, in fact, when looking at these images, we find that the level of subjective stressfulness goes up pretty significantly on a 9-point scale here, going from 0 to 9. You have pretty moderate to high levels of stress that remain sustained. So these images are coming at you, and there's a high level of stress. There's also a high level of subjective arousal. People are feeling distressed and aroused. And in fact, cortisol levels are going up relative to the neutral condition. What's happening in the brain here, this is what we call a functional MRI scan that these individuals participated in, where they go in and you saw those images, they're looking, their brain is responding to images and their body is responding to it. When you see red, yellow, it means increased activation. When you see blue, purple, it means those regions of the brain are showing decreased activation relative to baseline. And what we see here is that the limbic circuit or the emotional circuit, like the amygdala, as well as the hypothalamus, are getting activated under stress conditions. We also see that the prefrontal cortex, when it's blue, the regulatory regions don't have enough time. They are actually blunted. They're not responding, so that we are getting great stress response here and less amount of regulation. The important thing here that I want to point out is those striatal regions. The reward regions are also highly activated, and that's pointed right here, what we call the striatum. And so we became very interested in what is going on here, where we have emotional as well as reward regions activated. When you look at that rise in cortisol we do a whole brain correlation with cortisol, we see in fact that cortisol is influencing not just the hypothalamus and the amygdala, which is our limbic systems. This is cortisol response. This is the response in those regions, the amygdala, hippocampus, and the hypothalamus. A very tight correlation with cortisol response. In fact, the ventral striatum, the reward regions, and our prefrontal cortex are associated with cortisol, with our stress response. And the frontal regions, the blunting that we see, is in fact associated with cortisol. It doesn't mean there's a perfect relationship. This is just a correlation and not a causal connection. But more importantly, what we found is that in these individuals, we asked them on a separate day how they cope with stress and what are the things they do when they're under stress. And then we looked at their brain response. And what we found is during those 5 minutes of exposure to these images, these really awful adverse images, the brain starts to mobilize, and especially the prefrontal cortex and the striatal region, which you're not seeing here, start to mobilize during that period. And the degree at which we see a dynamic, flexible response in this reward pathway is associated with active coping. And in fact, those individuals who don't show a flexible or a dynamic response during the exposure to stress tend to be people who are emotional eaters. They are those who tend to have a lot of fights, or have emotional dysregulation, irritability, frustration. And most importantly for the talk today, that they tend to be binge drinkers. They tend to, in a sitting, tend to drink more than 6 plus drinks. So this was important for us to identify that in fact there is a stress resilient coping circuit that seems to overlap with our reward regions and are important in our coping with stress, as well as perhaps, as we thought, it could be important in coping with having a drink and knowing when to stop. So generally having a sense of self-control and being resilient under the challenge of alcohol-related stimulation, which we now think is a critical resilient coping circuit that's involved in active coping, motivation, and flexible control of behavior. Now, it's important to take a step back and say that there are individual differences in how we respond to stress. And most importantly, if we think about, there are some very basic hardwired differences between a female brain and a male brain. So if we just look at gray matter volume, this is not functional response or how dynamically our brains are responding to different stimuli. This is just gray matter, the cell volume. What we know is that females have less gray matter volume in emotional and stress regions. We talked about the amygdala, and right here we have the amygdala hippocampus regions bilaterally that are different, both in the adolescents as well as in the adults. And so these are separate groups of subjects, and we see throughout the lifespan, there are sex differences in how our brains are wired, particularly in emotion and reward regions, in emotion and stress regions. These are the amygdala, hippocampus, parahippocampal, even cerebellum, the motor the routine regions, and the thalamus. And so this is an important consideration. We'll come back to that again. Once again, now we want to go beyond the structural differences in the brain to the functional differences. And this is a group of young adult individuals who are social drinkers. And we looked at their brain's response to stress and to alcohol cues. This is a whole brain evaluation of their response. And you see here the amygdala and the insula response. And this is just telling us that this is where the hot spots are. When we break it down and directly compare males versus females, we see that under the stress condition, males actually have a higher response in the amygdala and in the insula regions. These are limbic regions, as well as in some prefrontal regions. However, females are much higher in that ventromedial prefrontal cortex region, which is very important in helping us regulate stress, as well as regulate our responses to alcohol-related stimulation. And so not only are we structurally different in males versus females, what I'm showing you here is that there's a different response to stress and to alcohol cues in men versus women. So sex differences are critical. When we then think about what alcohol does to our peripheral stress biology, we are back to cortisol here. Just levels of heavier drinking, binge drinking. Binge drinking here is 5 or more drinks in a sitting for men, 4 or more for women, as well as weekly 15 or more drinks per week for men and 8 or more for women. So the National Institute of Alcoholism and Alcohol Abuse has clearly identified these thresholds for binge drinking. And what we find is that individuals who are routinely binge drinking, they actually have an increase in their basal cortisol level. This is 2 separate studies. We find that compared to light moderate drinkers, cortisol levels at basal levels, this is at specific times of day, the binge heavy folks have a higher basal level of cortisol. And so we started to say, well, I wonder if this changes their response, the cortisol response to alcohol, as well as to their response to stress. So in a study where we wanted to look at the effects of cortisol and alcohol, we call it under implicit alcohol motivation conditions. This was a 3-day experimental study with social drinkers who were either light to moderate, never bingers, or binge heavy drinkers. And they were exposed to either alcohol cues or neutral relaxing cues or stress cues. And then they got to do this implicit alcohol motivation test, which is the alcohol taste test. It's been around for a long time. They get on a tray 2 glasses of beer, 12-ounce beers in each mug, and they're asked to taste it, to taste each one and to say whether they're the same or different. And they get to drink as much as they need to decide whether they're the same types of beer or not. Then they have a beer drinking period for about 10 minutes. And then we're looking at their body's response and their subjective response to the drinking. What you can see here is in making that determination of whether the beers are same or different, this is implicit motivation. Just naturally, the binge heavy individuals, social drinkers, drank more. So they felt like they had to consume more alcohol to make that determination compared to the moderate drinkers. And then what we find is, of course, they consumed more and they had a higher they had a higher cortisol response. But that's understood because that's expected because, in fact, alcohol will increase cortisol responses. It did so in both groups here, but we see that there's a higher and quicker response in the binge heavy individuals. So cortisol is sensitive to alcohol-related increases. What we also found, before they get to drink, they were exposed to stress and neutral and alcohol cues. And what we find is that despite the fact that basally they had a higher cortisol response, they actually have a blunted response to stress. When we stress people out, like I showed you right in the first study, cortisol goes up. And moderate drinkers showed an increase in cortisol, but binge heavy drinkers had a blunted response, both in the stress condition and the cue condition, no difference in the neutral condition. And more importantly, the more blunted their response was, the more they drank alcohol, which is really interesting. It wasn't high levels of alcohol, but in fact, a blunted response to stress was most sensitive in predicting how much alcohol they would drink right after. And so this allowed us to come up with a model that we are testing, a way of understanding these data, which is really identifying a role for glucocorticoids, brain glucocorticoids or brain cortisol in drinking. And what you see here is that here are the moderate drinkers, here are the binge heavy drinkers at basal state, and we see that the binge heavy drinkers are higher. So risk level is already going up. And then when we give them alcohol, they don't get as much of a response. So they have to drink more in some ways, if you think about it, to get their cortisol levels back up to functioning at a stress responsive or a challenge responsive level. And so this is our model that in fact, there is this disruption and there's a need to drive that homeostatic baseline back up to normal in some ways in binge heavy drinkers. And those who have the higher level of risk, this level of risk pattern, potentially could be those who have the greatest risk for developing alcohol use disorder. So let's make a shift then and think about alcohol use disorder. So the individuals who have been drinking and binge drinking and now are drinking more frequently and at higher levels and have developed alcohol use disorder, an episode of alcohol use disorder. The question we asked is, when they initiate treatment and they start to think about cutting back or abstaining. What are the challenges of maintaining that abstinence or maintaining recovery? We know that when people engage in treatment, there is a risk for early dropout. There is a risk for early relapse. And those factors jeopardize recovery. I'm going to, in fact, show you some data from our large publicly funded substance abuse treatment unit. This is 1-year data of 878 outpatients who have primary substance use disorders, either with cocaine, marijuana, opiates, or alcohol. And if you look at just the alcohol, what you see here on the x-axis is time to discharge, which is how long did they stay at the clinic for treatment. And on the y-axis here, you see their survival, meaning how long did they last, or what was, rather, it's much more the proportion who stayed abstinent. Not only did they last in treatment, that's on the x-axis, but really were they abstinent? What were the proportion who were abstinent at discharge? And what we see here, firstly, these curves are very important to see because you start to see people falling off the wagon. Everybody's abstinent in the beginning. When they come in, they can conjure up 1 or 2 days. And then what you see is that they start to fall off the wagon. In the case of alcohol, we, in this clinic, use the current alcohol use disorder medications that have been approved by the FDA. And in fact, people do pretty well. In 50 days, it's still about 75% who are staying abstinent at discharge. But then you start to see this dropping off, which is what we call both falling off the wagon, but also increased risk of relapse and jeopardizing of recovery. The key thing here that I want to show you is that this is a very dynamic phase. And you could think of it, at least in the initial phase, in 2 parts. The first part being in this first period, right here, the first month, we see a precipitous drop. And the question is, who's dropping out like that? And can we identify what is their risk profile? And what are some markers that can begin to tell us what gets in the way of both initiating and maintaining early recovery? And then we see in this second phase, again, some dropping off, going past below the 50% mark for alcohol use disorders. I just want to take a step back here and think about the patients. We had a patient who wrote to me about her experience of early recovery. And this is how she described it. At 8 weeks without a drop, I really notice I'm living less on instinct and habit. I can think much more clearly and take time to process thoughts maturely before acting. I even notice I'm just talking less. I haven't had fully formed thoughts for so very long. It's kind of nice to have my faculties back again. In the past, it's all been so superficial, just to get me from A to B, just to keep up the veneer of being a full human. But underneath, I was just a slave to the bottle, hungover, fighting myself, very much a knee-jerk reaction. But now, I'm no longer filling silences, nagging at my kids, interrupting people while they're talking. I'm just listening, not even planning how to react, just sitting with the moments and observing, hearing, feeling quiet and content in myself. I even think I found my chi. Without even knowing what that word meant a week ago, I felt something, like a place inside my soul, something I think I remember discovering as a child and teen before alcohol smothered it, a presence of myself. And we can come up with all kinds of quantitative data and analysis, but I think this is so beautifully articulated by a patient who's in early recovery, by someone who with alcohol use disorder, who's in early recovery and has managed to narrate her experience of those initial 8 weeks, and beautifully written. What we did in the laboratory is we wanted to understand this early period, and we had people come back into the laboratory and experimentally provoked their exposure to stress, to neutral relaxed cues, and to alcohol cues in the case of alcohol patients. And what we were able to do in the laboratory is experimentally induce an increased craving or compulsion for drug. And they're all inpatients in this case of the alcohol patients are. And what we see here is that stress provokes craving, as does alcohol-related cues compared to neutral cues. And in fact, that increased levels of craving when they're inpatient predicts what happens to them when they're discharged. And those who had higher craving tended to relapse more quickly. That slide is not in here. What you do see is that under those conditions of stress provocation or cue provocation compared to neutral, folks also had an increase in cortisol or a blunted response to cortisol in the case of patients. And what we find is the cortisol adrenocorticotrophin hormone ratio, which is a ratio of adrenal sensitivity, the higher that sensitivity, the greater the likelihood of relapse. So once again, what you see here is time to relapse post-discharge and survival. How many people survive without relapsing on the y-axis? And what you see here is that the CORT-ACTH ratio is in fact a predictor. And higher the CORT-ACTH ratio, the more quickly they are dropping off the wagon, the more quickly they are relapsing. In fact, by day 20 here, you've got most of those with the highest levels of CORT-ACTH ratio relapsing. But in fact, there is a range here. And so what we're seeing is that heavy levels of drinking does alter the cortisol and peripheral stress axis, but there's variability. And so it's important to understand the individual variation and identify those who are most at risk for this stress-related pathophysiology. Again, one of the factors that are important is sex differences, and ACTH, adrenocorticotrophin hormone, which stimulates cortisol in our adrenal cortex, is basally different for men and women. And these are those with alcohol use disorder, and we see females actually having a more blunted level during early abstinence. On the other hand, women have a much higher norepinephrine basally. And then that basal response also affects their response to stress and their response to cues. We also find that this is gray matter volume. So this is just structurally the number of cells, the number of gray matter cells that are there in different parts of the brain. This is a whole brain analysis that shows this prefrontal region, important in helping us regulate our actions, our emotions, as well as our reward responses, is more blunted, meaning that there's just lower volume, lower gray matter among those who are entering treatment, abstinent individuals with alcohol use disorder compared to healthy controls. And once again, those who have the lowest gray matter volume, they tend to have the greatest risk for relapse, the greatest risk for jeopardizing recovery and not doing well in treatment post their inpatient stay and inpatient treatment. When we look at functional response, both to stress and to alcohol cues, what we see is that there's a disrupted prefrontal and reward region response in individuals with alcohol use disorder compared to healthy controls here in the gray bar. Under neutral relaxed conditions, we see that individuals with alcohol use disorder actually have a hyperactive response to the relaxed state. If you're relaxing, your brain actually tends to deactivate, tends to go into blue, so to speak, for us among the healthy controls, but not so for those with alcohol use disorder. They have a higher basal state, and so almost like a hyperactivity that's remnant in this coping response, the stress and challenge coping circuit. And then under stress conditions, you see this blue here. Under stress conditions, we want this circuit to actually mobilize to respond to stress in an active way, in a resilient way. And in fact, those with alcohol use disorder show a blunted response. And more importantly, both the neutral response in this frontal region, as well as the stress response in this frontal region, is predictive of future relapse. So time to relapse post inpatient stay is affected, can be predicted by this disruption in the prefrontal cortex. And so those who have more blunting under stress conditions or greater hyperactivity under neutral conditions relapse much more quickly. And so what we think we've been studying and identifying with NIAAA's wonderful support is really coming up with a profile, a risk profile for alcohol relapse. What is it that jeopardizes recovery and increases the risk of relapse? Increased anxiety and provoked alcohol craving increases the risk of relapse. That higher basal quart ACTH ratio or higher adrenal sensitivity, and then a blunted stress response is also predictive of alcohol relapse. And then that hyper-responsive, hyperactive brain state under neutral relaxed conditions, and then hypoactive and unable to mobilize a stress response when in fact we need it under challenge conditions of stress or cue-related, alcohol-related stimuli being presented. And then just having less gray matter, having some shrinkage or reduced volume of the prefrontal cortex of our frontal regions of the brain also are predictive of relapse risk. So this starts to tell us that in fact we can begin to understand not only the effects of heavy alcohol use on the brain and the body that impairs our functioning just as our patient identified, but in fact also show that identify which measures, which of those biobehavioral measures are most sensitive in predicting or telling us that they're going to have difficulty in mobilizing recovery during the early phases of treatment. So what about clinical translation? The last part of my talk, I want to spend just a few minutes on clinical translation, both in terms of identifying, thinking about who is most vulnerable to these changes, just like data that I was showing you in terms of the spread of each of those markers. And can these biobehavioral markers identify those who are most vulnerable clinically? And then could some treatment help with reversing that risk pattern in the early phase? So of course, as we begin to think about precision medicine, tailoring our treatments and recovery mobilization to those who are most affected, we think about the disease pathophysiology itself. Severity of the illness, severity of alcohol use disorder, those who have acute withdrawal symptoms versus those who do not, how many days of abstinence can you conjure up? Do those factors actually impact this early phase of recovery? If a history of trauma and chronic stress impacts the early phase of recovery. I've already shown you that there are sex differences in the brain and body's response to stress and to alcohol. And in fact, that could have an impact on this early phase of recovery, as could be those who start early drinking in their teen years versus those who start in the later years. Other co-occurring illnesses may impact it, as well as genetics and having a more vulnerable genetic profile. I'm not going to have time to consider each of these moderators of those relapse markers, but I'm just going to pay attention to the very first one and talk about abstinence days as well as disease severity. So we used a different provocation method to once again do some experiments in the scanner using MRI to provoke stress and cues. So again, blocks of stressful images, but this time we added alcohol-related images and also neutral images, and you see this really nice 3-condition design. They are counterbalanced and randomly presented in blocks. So it allows us to look at what's the brain's response to alcohol-related stimuli, to stress-related stimuli, and then a comparison, the neutral stimuli. And we also ask them about how subjectively stressed they're feeling and how much craving they have. And I just want to show you what starts to happen. We've got different groups of individuals. These are light, moderate drinkers who never binge, who have never binged. These are our binge-heavy social drinkers. And here are the individuals with alcohol use disorder. And right away, I want to show you that under conditions of being exposed to stress, in fact, people are reporting high levels of stress. You've seen this in the previous study. And both groups here, the light, moderate, and binge-heavy social drinkers, show that. But look at our patients who are entering treatment. They basally have a higher level of distress. So there's been a shift in their stress biology that makes them feel more distressed to begin with. This is the dark side that Dr. Koob talks about. This is where he's talking about the withdrawal or the negative affect state of individuals suffering from alcohol use disorder. And then, of course, once they're provoked with stressful images, they also go up in their reporting of stress. What about craving? Once again, we see that under alcohol cue conditions, you see images of nice alcohol. We all tend to have a slight increase in desire for alcohol. So that's seen in the light moderate drinkers. That desire is much higher. Now it's craving in those who are binge heavy drinkers. They want it even more. What about our patients who are coming into treatment? Basally, they are shifted. They're just naturally craving more, basally. And then when they start to get stressed, or stress in the red line, or they get exposed to alcohol cues, they have greater craving. So craving is, in fact, a risk marker for continued drinking. And we have shown that in different ways. One of the things we noticed was that the brain in this early phase, these are treatment entering individuals who may have had 1, 2, 3, 5, varying number of days of abstinence as they're coming into outpatient treatment. And what we see is their brain stress response compared to neutral. Remember, once again, when it's blue, it's blunted. When it's red, yellow, they're activated. And we see the same pattern using a different experimental design. We see the same pattern, which is our reward instrumental coping motivation regions of the brain, right from the ventral striatum up into the prefrontal cortex, is blunted under stress condition, blunted under alcohol cue conditions in the patients compared to the social drinkers. And instead, the patients show a hyperactivity at the basal state. So their neutral relaxing state is hyperactive. It's as if there's this disrupted presentation of the brain's circuit, particularly the resilient coping circuit. It's under siege and is disrupted. And what we find is that, in fact, people who, this is the early treatment period, the first 2 weeks of engaging in treatment, and those who have a long period of abstinence as they enter treatment, anywhere between 5 or more days, versus those who have a short period, less than 5 days, so they just drank yesterday or 2 days ago or 3 days ago, there's a clear difference in how they're responding in the early phase of treatment. Those who have a long period can stay, so their probability of having no heavy drinking days is high. Whereas those who have a short abstinence stay period as they enter, they can't hold it together. They, in fact, start to go back to binge and heavy drinking days. And their brains, this blunted prefrontal response to stress and cues, is, in fact, predicting a return to heavy drinking days. So number of abstinence days matter. What about withdrawal symptoms and these abstinence symptoms? We know that people have a bunch of different types of alcohol-related symptoms. They're all listed here, whether it's craving, irritability, sleep difficulties, aggression, tension and anxiety, of course, headaches. There's a range of symptoms. What we decided to do was to really try to understand whether this early symptomatology is an important factor in identifying those who are going to both have the stress-related disruption that I've been showing you, as well as have difficulties in achieving recovery in the early phases of treatment. And in fact, those with alcohol withdrawal symptoms, which I showed you in the previous slide, report higher the alcohol withdrawal symptoms here is shown, higher the anxiety, depression, craving, and sleep problems. And if you just divide that based on the median split of the alcohol withdrawal levels, those with higher alcohol withdrawal, and in fact, have greater negative affect, depression, anxiety symptoms, and greater craving. So we decided to say there's this hyperactive state. It could be related to norepinephrine. And in fact, there's beautiful basic science data that shows that the prefrontal cortex and this instrumental coping circuitry is very affected by catecholamines or norepinephrine. And stress-related prefrontal function can be rescued by agents that, in fact, can reduce the level of norepinephrine in the prefrontal cortex and in these regions of the brain. We used an old agent like prazzacin. It's an antihypertensive agent, and with the help of NIAAA, conducted a proof of concept 12-week trial with 100 patients who enrolled in the trial. We measured drinking outcomes every day for the 12 weeks. The level of prazzacin versus placebo was 16 milligrams of prazzacin versus placebo, double-blind trial. And most importantly, people were able to go into this trial with no abstinence days required, so that those who were having difficulties in staying abstinent were still allowed to come into treatment. We did not ask them to be 5 days abstinent or 3 days abstinent. And those who had high levels of alcohol withdrawal may have gone for detox, but then came back and started treatment right after, started treatment in this study right after completing detox. And what we found was that alcohol withdrawal symptoms shown here on the x-axis actually moderated, which means it was a significant factor in how people did with prazzacin versus placebo. What do I mean by that? Let me show you. In red here is the placebo group. And this is across the 3 to 12 week period, average levels of drinking, heavy drinking days and any drinking day. And what you see is those on placebo just ramping up their drinking if they were those with greater alcohol withdrawal severity. And this makes sense clinically to us. If you have greater withdrawal and negative affect, you are in fact going to be relapsing or jeopardizing your recovery. But look at what prazzacin did. Prazzacin actually reduced that, reversed that effect in those with heavy or higher levels of alcohol withdrawal right here. This end is not different. Those with low to no level of drinking of alcohol withdrawal were no different in placebo versus prazzacin. So greater the alcohol withdrawal scores, better the level of prazzacin treatment response. What do I mean by that? This is just in the high alcohol withdrawal group. You see that drinking days, any drinking days, percent heavy, any drinking days or percent heavy drinking days was much lower, significantly lower in the prazzacin group here. As well as at week 12, you see much lower, almost down to 0. This is 7% by week 12 in those treated with prazzacin. We also found, which because of interest of time, I'm not showing you these data, that those on prazzacin in the high alcohol withdrawal group showed significant improvements in anxiety and alcohol craving and their mood level as well. And so prazzacin was having this benefit, but really only for those with higher levels of alcohol withdrawal. We also took a peek into their brain and we exposed them to alcohol cues and stress conditions and just looked at how they did from baseline compared to week 9 of treatment. So with chronic prazzacin versus chronic placebo treatment. And under stress conditions, we see, remember, red, yellow means the brain is coming back and is getting active, and we see the frontal cortex getting back and active under stress conditions. And on the other hand, in the cue condition, we see the striatal response in the placebo very overly active, and that's driving compulsion, driving craving. And so, in summary, I hope I have shown you that there are potent chronic alcohol-related adaptations in the stress pathways, both when we look at the brain, as well as in the stress hormonal system, which is in the periphery, and in the autonomic system, or our arousal, cardiovascular arousal system, which I didn't get much of a chance to talk about, but we find a similar pattern. And that these changes relate to the reward and motivation and instrumental learning circuits, which are part of our stress resilience circuitry. It's part of our coping circuitry. So in fact, heavy levels of alcohol and alcohol withdrawal and stress pathophysiology directly targets our ability to cope with stress and with challenge. And in fact, that is one major pathway by which alcohol recovery may be jeopardized. So what is it that we would like to do as we think about all of these biobehavioral markers that we've identified? We want to be able to identify those who have the most vulnerability in terms of alcohol's effects on the stress pathways. We want to develop these markers that can be, in fact, used in early treatment. As people are entering treatment, we get to assess that and say, oh, this level is looking too high for you, or your withdrawal symptoms are too high. we can't just give you one type of treatment. We're going to give you this other type of treatment. And so the next goal would be to have a personalized precision medicine goal, applying our biobehavioral markers to the clinical setting. How severe are you? How many days of abstinence have you conjured up? What is your threshold for cortisol, perhaps? What is your brain's response of hyperactivity at the relaxed state? All of those could be factors that can help us sort out who is most vulnerable to relapse and to jeopardizing their recovery. And then we want to have specific treatments, specific medications or strategies that can target that particular pathophysiology and help individuals who are most vulnerable to this early phase of relapse and jeopardizing of their recovery. So that's where we are headed with our work. And I want to go ahead and acknowledge all of the folks at the Yale Stress Center who have been part of developing all of these experiments and this research and conducting them. And a whole group of individuals over the years have contributed to this work. And none of this could have been possible without the support of the National Institute of Alcoholism and Alcohol Abuse. So we have a great debt of thanks to the Institute for supporting this work and for really putting forth knowledge that we think has moved the field forward in improving our understanding of what leads to greater risk of developing alcohol use disorder, as well as what gets in the way of recovery, particularly in the early phases, and how we can turn the course of that and improve our treatment outcomes. Thank you so much for your attention.